Hello, everyone. Welcome to part one of a two-part series on pharmacological principles in pharmacology. The first part of our lecture series is going to be focused in on pharmacokinetic principles. We kind of defined kinetics last week, and we said that was essentially kind of the effect of the body on the drug, right? And we also defined the other core principle, which is pharmacodynamic, which is like, what is the drug actually doing to the body? We're going to start with pharmacokinetic principles because that usually is a little bit more difficult for athletic trainers to grapple with. So we'll start with pharmacokinetic principles, and then we'll segue into our second online lecture on pharmacodynamic principles second. And so we're going to start with really a definition of pharmacokinetics, right? Kind of define that for you in the introduction of our lecture, but why not? So it's going to be the impact of the body on the drug, right? So if we ingest that drug, if we inhale that drug, if we inject that drug, if we rub the drug on our skin, what does the body do to that drug to create two kind of responses? Either it's going to give us the therapeutic desired response that we gave the drug to the patient for, or it's going to create an adverse and undesirable response, which we usually don't expect, but certainly can happen anytime we give medication to a patient. So when we think about pharmacokinetics, it's extremely important clinically, right? Because what we're saying with pharmacokinetics is, what is our body going to do to that drug? And then what effect is that going to have on our actual patient? And there are four kind of key pillars as we start to think through pharmacokinetics. And those four key pillars are going to be absorption, distribution, how the drug is going to be metabolized, and then how it's going to be excreted or removed from the body. And these four key pillars of pharmacokinetics, we're going to dive deep into those in this online lecture, right? But they're important because these four pillars, these ones that we just talked about here, really do three things for us or for our patient. Number one, they determine the magnitude and duration of the biological response, which if we're thinking about biological responses, what we're thinking about is what is the ultimate desired therapeutic response, right? Do we want to reduce pain? Do we want to reduce inflammation? Do we want to open up the airways for a patient who's having an asthma attack? If we have a patient who's allergic to something and we give them an EpiPen, right? Do we want to stop the anaphylactic shock? So what's the magnitude and duration of that biological response? The other thing that we see with these four pillars is they're heavily responsible for kind of determining the type of therapeutic effect that's going to occur and can be responsible for the adverse effects, right? More importantly, if we really truly do look at each of these four pillars, which of these do you think would be most responsible for the development of an adverse effect in our patients? Which of these? Do you think it would be absorption, distribution, the way the drug is metabolized, or excretion? Which of those do you think might lead to an adverse effect? Great. If you said excretion, right, then you would be correct. What happens if for whatever reason we can't excrete a drug or remove a drug from our system and it sits there and our patient starts to take more of a drug, right? That adverse effect could certainly be an overdose, right? Or if we are excreting the drug too fast, too soon, right? Then maybe we don't see as much of a therapeutic response because we're getting rid of the drug too soon, too fast. So we can see how these four pillars become important in the way that the body kind of processes the drug and really establishes the kind of rate, the magnitude, the duration of the biological response, and the type of therapeutic effect that we're actually going to see. Now, I mentioned those four key pillars here on the previous slide, so I'll go back here. I mentioned those four key pillars here, and then what I kind of wanted to do is actually like have you look at them from a different perspective, like to put the internal organs and the human body systems in an image, and then to kind of overlay those four key pillars. So that first key pillar was absorption, right? We said that. In order for the body to have an effect on a drug, we actually have to administer that drug, right? And so that administration can occur in different routes, and we're going to talk through those. But most common form of administration is typically orally, right? We ingest something. And then that drug gets absorbed. And most often it's going to get absorbed here in the stomach and then get transferred to the small intestine, where it's then it's broken down or is metabolized, right? Most metabolism of most medications that patients take will occur in the liver. So it'll get metabolized, it'll get broken down so that it actually can get used, and then it gets distributed, right? Now, of course, that distribution is going to depend on the goal of the treatment, but there are different sites of action, right? The musculoskeletal system, for example, the liver, the heart, if we're thinking maybe blood pressure, maybe the CNS, right? So we have different sites of actions as to where the drug can actually be delivered or distributed and create some type of effect, right? And last but not least, that drug gets metabolized. Some of that gets distributed, right? And then the part that doesn't get distributed gets filtered most often through the kidneys and gets excreted via urine. So we can see how these four kind of key pillars are kind of interlinked. Now, that was a quick snippet of what we're going to talk about. We're going to spend time talking through all four key pillars of pharmacokinetics in the next slide to follow. So we've talked about the four pillars of pharmacology, right? And if we were to go back on the slide, we would say that it is absorption, right? It's going to be metabolism, distribution, and excretion. We've talked kind of briefly through each of those kind of concepts, right? And what we said about each of these concepts is it seems like a straight fluid path, right? We administer a drug, it gets absorbed, it gets metabolized, and it gets excreted or distributed, right? And then it goes to what we call is a site of action, right? And we talked through kind of the four most common sites of action, either the CNS or the brain, the heart, the liver, or the MSK, right? So we kind of said that, but what exactly is an actual site of action? We know about site of actions is this. For any drug that we administer to have an effect, it has to reach that site of action. So it has to reach that brain, it has to reach the cell receptors in the MSK, has to reach those cell receptors inside the cell or inside the enzymes or on the cell surface. But it has to reach a target site. It has to reach an internal molecular site so that it can have a chemical interaction and create the desired biological effect. That desired biological effect could be a reduction in pain. It could be a reduction in inflammation. We talked about it, reduction in blood pressure, right? It could be maybe a relaxation of the airway to allow air to come in an asthma attack, right? But whatever we do, anytime we administer a drug, and I'm going to go back here for just a second to say that we have to make sure a few things happen, right? We have to make sure that enough of the drug is absorbed. Then we have to make sure that it's not just 100% completely metabolized and excreted. And then if we get to distribution, then we have to make sure that it attaches to a site of action so that it can actually create the desired biological response, right? Now, as we start to talk through sites of action, a few other key definitions become important on this slide as well. One of them is going to be the onset of action, right? The onset of action, if we could define that, would be the time it takes for a drug that we've taken to reach a high enough concentration at the site of action to cause what we call is a noticeable, I want to underline that, a noticeable biological response, right? And on this image here, we can see this. This is going to be, let's say, the onset of action. So I take the drug here. We can see that at time 0, right? I take the drug at time 0, but it actually takes about 30 to 45 minutes for the onset of action, right? So we have administration here, right? Let's say we ingest the drug, and it isn't until about 30 to 45 minutes into it that we actually start to have what we call or experience what we call is the onset of action, right? The onset of action is typically not instant for most drugs. So that onset of action, again, defining it, we would say that we have to take the drug has to be absorbed, right? Enough of the drug has to be absorbed and then metabolized and then distributed, right? So we're in the distribution phase of this and we're saying how much of that drug got absorbed, how much is left over and has been metabolized, and then is there enough left to attach to the receptor site to cause a desired noticeable therapeutic response. Once the response is noticeable, that's when we actually say that we have what we call is an onset of action. There's enough of the drug at the site of action to cause the desired noticeable biological response. Now, what are some desired noticeable biological responses? We'll take a patient who comes into us with an ankle sprain and who can't walk because they have so much pain. So a desired noticeable biological response, if we were to give them Tylenol or ibuprofen, would be a reduction in pain. We all know that if we give a patient Tylenol or ibuprofen, their pain doesn't go away the second they ingest that medication, right? It usually takes a little while for the pain to start to drop. Well, that little while, that time that they actually start to notice that pain has reduced, that's called the onset of action, right? That's the first time that we notice a change in the patient's response, right? Now we have this other concept called the duration of action, right? And I think that's more intuitive. So we have the onset of action. Let's just trace this. We have the onset of action. We take a drug, but the drug doesn't get absorbed, metabolized right away. It starts the process of absorption, metabolizing up right about here. My patient starts to feel a reduction in pain. There's a high enough amount of drug at the site of action to cause a noticeable biological response. That is the onset of action. That in this particular patient, maybe it happened at about 30 to 45 minutes. So we have the onset of action, noticeable biological response. Then we have something called the duration of action. So that duration of action, once we ingest it, once we have enough of the drug at the site of action to cause a noticeable change, then we have this thing called a duration of action. The duration of action is what? What is it? The time between the onset of action where we first started to notice the change to the time of the termination of action, the time when we realize the drug is no longer exerting a biological effect and is no longer producing any type of effect on the particular patient. That's the duration of action, right? So in this particular patient, we can kind of see that duration of action if we start maybe at 30 minutes and if we go all the way to about 4 hours and a half, we had about 4 hours where that drug was relatively active and caused a noticeable biological effect. But at 4.5 hours, we also saw that the drug then tapered out. And so it wasn't as effective. There was no noticeable biological effect. And we call that the termination of the action of the drug, right? Now, what we know about a drug is that once it hits the site of action, once it's actually in the bloodstream, we have two other pillars of pharmacokinetics. We have metabolism and then we have excretion, right? And those two key core pillars are working as the drug is at the action site, right? From the moment we ingest a drug to the moment that it gets distributed to the moment that it gets excreted, it is constantly being metabolized and broken down so that it can be excreted, right? So we have this thing in pharmacology called a half-life. And as the name implies, when we're defining what half-life is for a drug, we would essentially say it's kind of the time required for the amount of drug at the action site to be reduced by 1/2. So let's think about it this way. If I take 400 milligrams of ibuprofen, how much time does it take to reduce that 400 milligrams to 200 milligrams? How much time does it take to reduce that 200 milligrams to 100 milligrams? That is a half-life of a drug. And this is extremely important because it's the variable that allows us to know when we should have a patient take another dose of a drug, right? And we can think through maybe ibuprofen, for example. Maybe the back of the box tells you take this every 4 to 6 hours. One of the reasons for that variation in dosing is because they know that the half-life of that drug is 4 hours. So what they're saying is if you want to maintain and have a longer duration of action, you need to continue to take this drug every 4 to 6 hours to maintain that level of concentration so that we can see that noticeable biological effect, and so that we don't then have a termination of action, right? Everybody tracking there? I hope so. Okay. So when we think about clearance rate, then if we're really defining that, what we're really looking at is how well can we metabolize a drug, right? And then how well is that drug then cleared from our body? That would be the clearance rate. How effectively do we metabolize the drug? How effectively and how quickly do we excrete the drug? But again, that also has an impact on the half-life, right? The quicker we metabolize and excrete, the shorter the half-life is, which means the more we have to take of that drug, or the more often we have to actually take that drug over time. Now, our next definition is going to be bioavailability and bioequivalence. So I'm going to start with bioavailability first because that's the more common term of the two, and then we'll get into bioequivalence. So when we think about bioavailability, how would you define that? Break that down. Availability, how much of the drug is actually available, and then biology, so how much of the drug in the body or in the systemic circulation is actually available to us to be used at the site of action. Another way to say bioavailability is to say how much of the drug that we administered is actually going to be available at the action site to cause a biological response. That would be bioavailability. The hard part with bioavailability is it's really dependent on kind of two key components. The first one is the amount of drug that is going to be absorbed, and then the rate at which that drug is actually absorbed. And those are two kind of different things, right? So the first one is how much of the drug that we either orally ingested or injected or inhaled, how much of that drug is actually going to be available to us after we metabolize it and break it down, right? How much of it is going to be available to us? And then based on how much is available, how quickly or slowly will that be absorbed and then be distributed to the site of action, right? And there are a few key things that are important with bioavailability. And one of those is a concept known as the first pass effect. One of the things that's really hard anytime we kind of orally ingest a drug is we know that there are two sites that kind of break down drugs. The gastrointestinal tract, which most orally ingested drugs will pass through. That typically will cause metabolization and breaking down of the drugs. And then we also see oftentimes that the liver is a major organ of drug metabolism. And so that if, in fact, a drug is somehow absorbed by the liver, we also have a quicker metabolism. And so the drug becomes inactive. And so we have less of the drug kind of available for the site of action. And that's a first pass effect. So we take the drug, automatically it goes into the gastrointestinal tract, and right away, unless it gets moved to the small intestine, if it sits there, then it breaks down. And so we have less of the drug available to move into the small intestine. That's the first pass effect. Most often we can do nothing about that. The great thing about the first pass effect, whether it's the drug being metabolized by the liver quicker or the drug sitting in the GI tract and getting inactivated by some of those enzymes that live in our intestinal walls, is that most drugs that get impacted by the first pass effect have some type of protective coating. So they are already prepared in the pharmacy for this first pass effect, but it is something that reduces the amount of drug available in the blood to be delivered to the site of action. And it's something that we should consider anytime we actually administer a drug to a patient. Now, bioequivalence is a little bit different. It certainly is a concept of bioavailability, but bioequivalence is when we look at two very similar drugs. So we look at the generic version of the drug, and then we look at the brand version of the drug, and we look at when a patient takes both of those drugs, that's the bioequivalence. Are they equal? Does the bioavailability break down once the drug is metabolized? In other words, do we see acetaminophen versus APAP, for example? Those are two I'm thinking of right off the bat. Acetaminophen, Tylenol, APAP. Do those drugs, when they're ingested and get absorbed, do they have the same bioavailability physiological processes, or are they different, right? And so we want to know in our generic drugs in particular that it's always bioequivalent to the brand form, right? We don't want that generic drug to break down quicker, to get excreted or metabolized, so there's not enough available to produce the desired biological effect, right? So I hope I explained that well. So as we look through these definitions, these are key. These are huge for us to understand. Understanding that when we administer a drug, we need it to go to the site of action, and we need enough of that drug to reach the site of action in order to cause a desired biological effect. And when we have enough of the drug circulating through the bloodstream and it produces the first noticeable desired response, and that's the onset of action, right? And then we look at, okay, how long does that desired response last? That's the duration of action. And when does it go away? That's going to be our determination of action. And then if I could summarize, bioavailability means how much of the drug, after it's absorbed, after it's metabolized, how much of it is actually available to travel to the target site to exert a clinical response or a biological response. And then if you have patients who maybe have a generic drug and they're struggling between generic drug and brand name drug, then the question just becomes, are they bioequivalent? Do they go through the same process? Are they excreted the exact same way at this exact same rate? And really, do they have the same clearance rate overall? So let's look at bioavailability a little bit deeper. We said, okay, bioavailability, if we broke that down, available biology, so it's the amount of drug that's going to be available to produce a biological effect kind of after it's been absorbed, after it's been metabolized, then what's left over to be delivered to that actual site of action, right? But then we can see that bioavailability can be affected by kind of three key things. And so we'll break those down just a little bit. The first is the amount of drug that's actually absorbed, right? So we ingest and swallow a drug, and then we have to say, okay, how much of that is actually going to be absorbed, right? That can be impacted by its formulation. So what do I mean by that? It's chemical makeups, right? So formulation can refer to the contents and type of dosage form. So example would be gel tablets versus powder tablets versus syrup or liquid, for example, right? But then if we move back, the amount of drug can also be impacted by three kind of distinct or indistinct processes. The first one is we can have a drug that gets absorbed and moves into the GI tract, and in there it stops, right? So there's incomplete absorption of the drug in the GI tract. In other words, the drug just becomes consumed by the gastrointestinal tract and does not get transmitted to the small intestine, right? The other that we can see is that we have these kind of enzymes that live within the intestinal tract, which can also cause inactivation of the drug. And so if there's inactivation of the drug, essentially it leads to the same thing that incomplete absorption in the GI tract leads to, which is less drug is available to be delivered to the site of action. Therefore, we don't see the desired biological effect being produced, or it doesn't last as long. The other thing that can affect the amount of drug being absorbed then is going to be the drug being absorbed by the intestine, but then directly entering into the liver, right? And we know that if it goes to the liver is one of the main sites for metabolization. And so what that means is part of the drug becomes prematurely metabolized. And then we know this as a first pass effect, right? So it's metabolized early through the liver because it hasn't been distributed yet. And so then again, that leads to less of the drug is still available, right? And that's really a concern for us. Everybody's seeing that, yes? We want as much of a drug available to us to be delivered to the site of action so that the concentration is high enough to cause a noticeable biological response or to create what we call as an on-site of action, right? Everybody tracking there? Okay, the other thing that would affect bioavailability is going to be the rate of absorption, right? So in other words, how quickly or how slowly the drug enters into circulation to be delivered to the site of action, right? That's most often going to be impacted by the chemical nature of the drug. and its lipid or water solubility, which we'll talk about. So we have to consider all of these things as we're having our patients take these drugs, that we need we need a high enough amount of the drug to be delivered to the site of action. Yet we have all of these things. I hope you're seeing that all of these items, which can certainly impact the amount of drug that's available to us to be delivered to that site of action. And we have to keep that in mind as we work to administer medications to our patients to make sure that they're actually getting the most out of the medications that they're actually taking. So let's take a look at this graph here, because I love it when you all can see kind of things kind of coming together. So on this axis here, what we have is the plasma concentration of a drug, or the amount of drug that's available to be delivered to the actual site of action. And then the maybe amount of time that the drug is actually in the blood before it's actually excreted. So we have drug A, B, and C. So we can see from this image is drug A obviously has higher plasma concentration. Drug B would be second. And then we have, I'll do drug C, which is going to be last. What we can see is this dotted line represents the minimum effective concentration. So let me say it to you this way. We at least need to be above this line to actually see a noticeable biological response. Everybody tracking there. What that means is drug C is never going to hit an onset of action, right? Because it's not going over, I'll remove my lines. It's not going over the minimum effective concentration kind of threshold, right? Drug A and B, however, both, we can see that they both hit the minimum effective concentration. So they're going to cause a noticeable effective biological change in the goal. So if it's to reduce pain, they're going to do that effectively. If it's to reduce inflammation, they're going to do that effectively, right? But there's a difference in the bioavailability of all three of these drugs. Are you seeing that? I'm hoping that you are, right? So we can see that even though drug A has a higher plasma concentration, right, and is probably going to create a greater desired biological response, what's one thing that we see with drug A that we don't see with drug B? What do we see? It's not going to be as biologically available as drug A, or let's look at it this way. The duration of action for drug A is going to be a lot shorter than that for drug B. So you have to decide right here between drug A and drug B. Which one do you want to utilize for a patient who's in extreme pain? Do you want the drug that's going to reach more? Do you want the drug that's going to reach the site of action and have more of the drug available for a shorter period of time? Or do you want the drug that's going to reach the site of action, not have the higher concentration, but last longer, right? So we can see differences in bioavailability. We can see that one is going to cause a quicker onset of action than the other, but the other is going to have a longer duration of action. And so these are all things that you have to think about as you start administering medication to your patients. So we've talked a little bit about absorption, and we're going to go deeper. And the next is going to be distribution, right? Which is extremely important. Distribution, if we kind of define it, would be the drug has been metabolized, is broken down, and now we're taking whatever's available to us and delivering it to the site of action, right? And that sounds way simplistic, and it really isn't. So I'm going to start with volume of distribution first, and then we'll kind of dive deeper into protein binding a little bit. First and foremost, when we think about distribution, we have to think about the volume of distribution, which is basically the space in the body that is available to the drug, right? So how much of the space in our patient's body is available to that drug. And that has to do with receptor sites, right? Some drugs are going to be more selective to specific receptor sites, and some are not going to be selective at all and can bind to more receptor sites throughout the entire human body. So one of the questions that we always have is, how much of the body is actually available to the drug? We know, and we could probably kind of presume that the more extensive the distribution, the larger the volume of the drug. So what we would want is that as we ingest or inject or rub a drug on a patient or administer a drug to a patient, We want to make sure that that drug is going to distribute well. And one of the things to consider as we think about volume of distribution is this concept of lipid solubility. And so what do I mean by that? Well, we know about the body is that we have a lot of adipose tissue. And if you've learned nothing, you will learn a lot about this in modalities, is that adipose tissue is a very selfish tissue layer. In other words, it likes to absorb a lot of the things that we put on our body or put in our body, either whether that's through electrical modalities or whether that's through pharmacology. And so because we have adipose tissue, which is an insulating layer, and we need that, what we know about that is it likes to absorb a lot of the medications that we administer to our patients, whether that's us rubbing it on or us ingesting that or us inhaling that. Oftentimes the adipose tissue layer truly wants to absorb most of that medication, which means if it does that, right, if the adipose tissue layer absorbs a lot of the medication that we are administering, then there's less of that medication available to distribute to the site of action. One of the things that we know about the volume of distribution, however, is that it is most often impacted by the lipid solubility of the drug or the drug's ability to bind to specific proteins within the body. So the ideal is that when a patient ingests a drug, it's lipid soluble, meaning it can move through the adipose layer and then be distributed to the site of action. There are some drugs, however, that we'll discuss in the next few weeks that are not lipid soluble, but then have what we call our strong binding protein characteristics. One other thing to consider with volume of distribution is the size of the patient, right? We know that the larger the patient, the more drug we're going to need to distribute, because that person is going to have more apparent space, right? Which is why oftentimes if we look at medications, specifically for children and adults, there's a major difference, right? Children tend to be smaller, so they need less dosing. We have less volume of distribution. Adults tend to have higher dosing because we have more volume of distribution. So that seems pretty, I think, intuitive to hopefully all of us. So we've got lipid soluble drugs, or if they're not lipid soluble, then we have to find drugs that are capable of binding to proteins. And so we're going to talk about protein binding. One of the things that's really truly neat to see is this idea that we have a natural kind of protein circulating in the bloodstream. That natural protein is called albumin. A lot of the drugs that we ingest or take orally have the ability to interact with albumin. And so I'm going to come kind of back to this side of the screen so that you can see this image over here. And so what we can see is, so we ingest a drug, right? We ingest a drug, that drug begins to get absorbed, right? And if they're lipid soluble, they'll go right through the lipid layer and then into the target tissue and hit the site of action and cause a biological response, right? But not every drug that we take is going to be lipid soluble or highly lipid soluble. And so then it gets absorbed by the adipose layer. So one of the things that we can do is a pharmacist can create a drug that also has the ability to bind strongly to naturally circulating protein, in particular the albumin. The beauty with the albumin is any drug with a protein binding capacity can bind to it. And so it can bind to it quickly, and it can then transport that drug into the capillary so that it's not getting absorbed by the adipose layer, right? And that's beautiful. And the other thing with albumin is it's non-selective reversible binding. So in other words, the drug binds long enough to get into the capillary, and then it frees itself, you can see it here, and it becomes what we call is a free drug. And now that free drug, once it unbinds, can now be delivered to the target tissue site of action area to create that biological response. So if a drug isn't highly lipid soluble, then hopefully it has some of those protein binding characteristics, and it can utilize albumin to move into the capillary, unbind from albumin, and then move into the target tissue. Now, none of this you're seeing, right? The only thing you have to ask yourself and to consider is if I have a highly obese patient with a lot of adipose tissue who's taking maybe, let's say, a low lipid soluble drug, then that's probably not the best drug for that patient. I probably need to find a protein binding drug, which can indirectly bind to albumin, release itself while in the capillary, and then move into the target tissue. So those are things to actually consider as we start thinking about the drugs that we administer to the patient. We want to be more selective in that actual process. And then finally, we move to the chemical structure of the drug, right? The chemical structure of the drug is obviously going to determine the biological effects of the drug, right? And let's think about two very common analgesics that we can get over the counter: acetaminophen and aspirin. Both are over the counter analgesics that we can use to reduce pain, right? But we also know that these drugs are vastly different and they have unique chemical characteristics. And as such, Tylenol, for example, or acetaminophen can't be used to reduce inflammation. However, aspirin, even though they're used for and marketed as analgesics, we also know that aspirin can be used as an anti-inflammatory medication as well as an analgesic. So we can see how the chemical structure of a drug definitely can determine the biological effects that it's going to have on our patient. In addition to that, we have to also think about, when we're thinking about chemical structures of a drug, the size of the drug, right? That the patient is taking, kind of the chemical shape of the molecule that the patient is taking, and then the solubility of the drug. And if I had to argue which of these would be most important, probably the solubility, right? We just talked about lipid soluble drugs and how when they're highly lipid soluble, they can move through that selfish adipose layer quickly to reach the site of action, right? Drugs that are less lipid soluble, again, they either have to bind to that albumin or most of it gets absorbed by the adipose layer, and there's less of the drug available for distribution to the tissue site. So as we look at this slide, lots of things to consider as we start to administer drugs. What's the volume of distribution? How much of the patient's molecular structure is available to this drug that we're getting ready to give them? What's the size of the patient? How obese is the patient? What type of drug are we giving them? Is it lipid soluble? Is it not lipid soluble? What's the chemical structure and makeup of that drug? And all of these become important because at the end of the day, as clinicians, what we care the most about is, are we going to give patients drugs to create a biological response? And if we aren't, if we're just giving them the drug just to give it to them, then maybe we consider other alternative treatments for that particular patient. So I've been mentioning drug solubility, and I mentioned it on the previous slide, but let's dive deeper into drug solubility because it's so important. We think about how well a drug can move through the different layers, different tissue layers, to get to the site of action. This is probably one of the key concepts that's important in pharmacokinetics. And so what we know about the drug solubility is it's going to impact several properties of the drug. First of all, how fast it dissolves in the gastrointestinal tract, how quickly it's absorbed, particularly how much of it is going to be absorbed or how much is left to be distributed to the site of action. The other things that we can think about is how quickly it's excreted. We know that water-soluble drugs are going to be excreted a lot quicker and reach the site of action less when compared to our more lipid-soluble drugs. And so then the two different categories for solubility are going to be kind of water-based, hydrophilic, or lipid-based, lipophilic or hydrophobic, depending on how you look at that. And so look here, I love some of the images in your textbook. So first, there's a drug, right? It has the chemical properties. And most often it places them into one of two categories. Okay, I say one of two because certainly you can have a drug that is more lipid soluble, but certainly water soluble and vice versa. If it's more lipid soluble, it is capable of crossing membranes faster. So if I go back to this slide, it's going to be capable of getting to the site of action, this tissue, quicker and exerting a biological response. The other interesting thing about lipid soluble drugs is oftentimes you don't have to take as much of them to see that desired onset of action, right? But then on the other side of the chart, we have those more water soluble drugs. And are they capable of getting to the site of action? Absolutely. But they take a lot longer to cross the membrane. Either they have to be protein binding and they have to attach to that albumin, or they get metabolized quicker and excreted quicker. And so therefore there is less of the drug available at the site of action. So what am I saying to you as healthcare practitioners? As we get into specific drugs, we will talk briefly about which of those are lipid soluble and water soluble, and you should use those to drive your decision making as you start to administer drugs to your patients for specific treatments that they come into your clinic for. So now that you have like kind of a basis for the different categories of solubility, whether that's water soluble or hydrophilic, lipid soluble or a lipophilic, and we know that drugs that are more lipophilic will cross the membrane faster, and drugs that are more hydrophilic it'll take a little bit longer and might require more work of the drug to binding to proteins to move them across the capillary into the desired or target tissue, right? So then let's talk about drugs actually crossing membranes, right? Because that's really what it's all about. One thing that we should probably really think through is regardless of the drug's chemical structure, right? We talked about how chemical structure can kind of impact whether or not the drug makes it to the site of action. Every drug has to, at some point in time, reach the site of action to produce a desired therapeutic effect, right? If the drug doesn't reach the site of action, or if enough of the drug doesn't reach the site of action, then we might as well not be utilizing the drug, right? Okay, but in order for that drug to reach the site of action, remember, if we were to go back, let's just go back. I don't like doing this, but let's go back here. If we were to just look at this and go, yes, we take the drug, it gets absorbed, it gets metabolized, it gets distributed, and it gets excreted. If that process were just so easy, right? Like if we were to think about it that way, then every person who took a drug would have the expected desired therapeutic response. The reality is, though, right, that doesn't always happen. And so to reach the site of action, we know that drugs have to pass through some sort of membrane or two or three. That membrane could be the gastrointestinal tract. That could be traveling through your capillaries, your veins, your arteries. That could be cellular or intracellular. The reality is that drug gets absorbed, gets metabolized, gets absorbed again, gets metabolized some more, might get distributed, metabolized, distributed. You get the point. And through that process, that drug is traveling through different membranes, right? And we know that the more lipophilic the drug is, the easier that process is for the drug to reach the site of action. And the more hydrophilic that drug is, the more work that drug has to do to get to the desired site of action, right? Okay, I want you to understand that, because then what I want you to understand is that cell membranes, most of them are comprised of lipids, particularly the phospholipids and the cholesterol, which is great because, again, if we have a drug that is very phospho forward, then we know that it's going to have an easier time crossing that cell membrane. We know that it's going to have an easier time attaching to that site of action. And the beauty of that is creating that desired therapeutic response, right? Now, within your cell membrane, right, it's comprised of lots of lipids, but then in the center portion of that cell membrane, what we also have are those protein-like structures which cells can bind to and then get delivered to the target site. So there is something to suggest that both water-soluble and lipid-soluble drugs, both of those certainly can, if delivered or distributed to the site of action, can exert an effect. It's just how difficult it is to actually get there, if that makes sense. So let's talk through the different ways in which drugs can kind of be transported across cell membranes. The most common form is going to be passive diffusion, right? And that, I think, is kind of intuitive. It's not going to require a lot of energy from our systems. So when we think about something that's very passive, it doesn't require a lot of work to get the drug to penetrate and move through to the cell membrane, right? So that drug is going to penetrate through the cell membrane, and it's going to be because of its solubility. Its solubility properties. That's what I wanted to say. So anytime we have a lipid soluble drug, a highly lipid soluble drug, Really, if we're looking at this image here, you see it here? Everybody seeing that here? As long as the drug is moving from higher concentration to lower concentration, no energy is needed to transport this drug across the actual cell membrane, right? Because we know that membranes are primarily composed of lipids and cholesterol. Therefore, drugs that are more lipid soluble will diffuse across that membrane way easy, right? As long as they're moving from a high concentration gradient to a low concentration gradient. Now, the opposite wouldn't apply. In passive diffusion, we couldn't have a drug moving from a low concentration to a high concentration. That would actually require energy. And so that's where we look at actual active transport mechanisms, which is going to be the second way that drugs can be transported across the actual cell membrane. And when we think about active transport, as the name implies, that's where we're actually going to bind to albumin, for example, right? And then that albumin kind of is responsible for transporting, right, that drug across maybe a compound, and then it unbinds and then moves into the target tissue site. So you have the protein actually doing the job here. The beautiful thing about the active transport system, one of the things that I really love about it is the drug can move in both directions. So it can move from low concentration to high, and obviously it can move from high to low. But when we look at active transport, we have the drug binding to a protein to be moved, right? That's where we get the active portion there. And then last but not least, you can have facilitated diffusion, which is kind of a combination of both passive diffusion and active transport. So in this process, it requires a carrier protein, whether that's albumin most often, right, to carry a medication from a higher concentration to a lower concentration. So you get both. You get passive because we're moving from higher concentration to lower concentration, but you get the active because you have the binding of the drug to the protein to be carried from that higher to a lower concentration. So you can see there's passive diffusion, which is the ideal. There's no energy systems being utilized. There's no reliance on a protein to move us across the lipid membrane. You have active transport, which says I have a hydrophilic drug that needs something to bind to get across the membrane, right? That something's most often going to be albumin. It's going to carry that drug across the cell membrane and deliver it to its site of action. Or you can have facilitated, which is a combination of both of the different types of transportation processes. So now we get into the fun part. We've had lots of definitions. I'm going to throw maybe 4 more at you, which are extremely important. So first and foremost, route of administration means how were the drugs put into contact with the body, right? Oral administration, injection, inhalation, right? Those are all considered routes of administration. Then we have our dosage form, right? So that's a physical form in which the drug actually exists. So that could be capsule, that could be syrup, that could be tablet, for example, right? So what is the form of the drug that the patient actually is going to orally administer to themselves? And then some things to consider as we're starting to decide which drugs might be good for our patient. The age of the patient. Example, if I have a child, a pill most often doesn't work, right? Or a tablet or a capsule because of their gag reflex. So I might consider a syrup or an elixir, for example, right? The cost of the drug, generic versus brand, and then the speed of the onset of action, right? The ideal would be to have a drug that has a very short onset of action, right? A drug that has an onset of action of about 30 to 45 minutes so that we can start to see and feel that desired biological response. And then we have to consider the absorption. And in particular, what I really want to focus here is lipid solubility, right? Because if a drug is more highly lipid soluble, then we know a few things. Passive diffusion, there isn't any energy required. The drug doesn't have to work hard to be transported over the cell membrane to get to its desired site of action, right? In addition to that, other things that we also have to consider is the route of administration, right? Which is going to be linked back to this. We know that intravenous administration, intramuscular injections, those go directly to the site and have rapid, right, onsets of action. Whereas most drugs that we take via oral administration, they just have a longer onset of action because we're not directly going to the site of action. And there's a process. There's absorption, metabolism, distribution, and excretion that has to actually occur. And then the other thing that we can consider is blood flow to the site of administration, right? We know oftentimes that increases in blood flow to specific sites can be great, particularly as we're thinking about things that we rub on our skin. We have increased blood flow to that area prior to rubbing that medication into the skin. We know that it's going to distribute that drug quicker, more efficiently, and more effectively. So these are all things that we should consider and at least definitions that we should know. And now we're kind of going to move forward to routes of administration. And we're going to talk through all of the routes that are, I guess, possible for us as healthcare practitioners, athletic trainers. So the first and most common is going to be orally, right? So we either drink a syrup, we take a tablet and or a capsule. And so there are many advantages to taking drugs orally. It is the cheapest. Like when you look at the research and you look at the cheapest route of medication, most often it's going to be orally, whether that's in the form of a tablet or an elixir or a suspension. This tends to be the cheapest because most of these things are going to be over the counter, and over the counter is always cheaper. In addition to that, because most of the items in this list are over the counter, they're also convenient. And the reality is oral is actually the safest route of administration for most patients versus inhalation versus injection, of course, right? Versus IV, because those are going to also require some sort of training. The limitations, however, we've kind of talked through this a little bit, but we'll talk about a little bit more here, is inactivation of the drug from the GI tract, right? So it can sit there and get inactivated either via the enzymes, or it could just be absorbed. We can have that first pass effect where it goes from the small intestine to the liver, where it's metabolized and broken down, and so we have less of the drug available to distribute, right? If the patient is larger in size, and let's say we have a hydrophilic drug and not a lipophilic drug, and a lot of that drug gets absorbed by the adipose tissue, the length of time it takes for the drug to get absorbed, this is a big thing, right? If we were to go back and look at the system, we have to ingest the drug then has to go through the airway, right? Then it has to go through small intestine, large intestine, all of those areas before it gets to the small intestine. So there's lots of different areas in which the drug can be absorbed before it actually gets to distribution. And then we just have to think about patient characteristics. So what if I'm a patient who can't swallow and has an increased gag reflex? Then maybe oral routes of administration might not be the best route of administration for me. Now, of course, we have to consider the different types of drugs that can be taken orally. So we have our tablets. This is probably the most common form of oral administration. This is the powder-like pill that we would mostly take. It's not covered by anything, right? So it's like the white pill that we would take. Your capsules, those are my favorite, right? They slide through the throat easily, and that's because there's usually some form of gelatin covering or encapsulating the powder, so they tend to go down a little bit easier. And then these next four are all fluid-based substances. Your syrups are most often what you'll see over the counter. Your syrups typically do not contain alcohol. And if they do, it's a very small percent. But your cough syrups, for example, your elixirs are going to contain, think EE, ethanol, alcohol. It's about 70% of this solution is going to be alcohol. So this isn't a very friendly kid-based substance, but elixirs are great when you have a non-productive cough and you need to sleep. This is going to be the syrup that most often is going to, or elixir is the one that's going to help you sleep a little bit more. Then you have suspensions. It's a liquid consisting of a phase system. So you have a solid, which is going to be dispersed throughout a liquid, and it's going to break down within that liquid form. So suspensions, oftentimes you have to actually shake them. I don't know if you've ever seen that before. You'll have to shake them in order to kind of activate them just a tad bit. And then you have emulsions. And this is to make something a little bit more lipophilic. You'll put a little bit of oil in water to break down the drug, and this will make the drug a little bit more lipophilic and a little bit more friendly to cross the cell membrane. So these are kind of the types of dosage forms for oral administration. Probably most common forms utilized in the field of athletic training, your tablets, your capsules, and your syrups most often. Now let's talk about how we kind of make oral administration very effective. So when someone takes something orally, the thing that you want to think about is the rate at which it's going to be absorbed and the extent at which it's going to be absorbed. And there are certain things that can impact that. First of all, the solubility of the drug, right? One of the things that is extremely important, and I tell this to my husband all the time, he takes a pill without water, without milk, without soda, without anything, without any fluid. But this is extremely important because what we know about taking a drug with the fluid is the fluid will start to kind of break down the drug so that it can be absorbed in smaller pieces, right? Quicker the drug dissolves, the quicker the drug can be absorbed, right? So we want to always have our patient take something with their, at least with their tablet and or their capsule, right? With your syrups or your elixirs or your suspensions or emulsions, their fluid form. But with any pill, you want to make sure that the patient is drinking something with that. The other thing that will impact oral administration is the rate at which the drug passes through the GI tract, right? Remember, if it sits there too long, it can either be rapidly absorbed or the enzymes can inactivate it. And so what we want to have happen is we want that drug to pass from the GI tract to the small intestine, where those villi and microvilli can kind of increase the surface area and push that drug along in the system. I've said this multiple times. I will say it one more time here. The more lipid soluble it is, the more we can use passive systems and not active systems, and those drugs can be diffused through the cell membrane easier over time. And then again, with the GI content, just remember that if in fact a drug is allowed to sit, it can either become inactivated or absorbed by the GI tract. Now, there are other factors that affect absorption. So we talked about the effect of other GI contents. So if in fact the food moves slow, let me say this again. I'll say it the opposite way. If you have a patient who eats before taking a drug, that's the way that I want to say it, it will slow down the rate at which the drug is absorbed, because first we have to process and break down the food before the drug can move through the system. So in fact, the recommendation for most drugs is actually to take it on an empty stomach, right? So I hope you caught that, right? That if in fact we allow a patient to eat prior to taking a drug, that either some of that drug is just going to be absorbed in the GI tract because we still have to process and break down the food that exists there. And so it's going to slow down the movement of the drug from the stomach to the small intestine, making it more readily available to be absorbed or inactivated by the enzyme sitting in the GI tract. So that's just something to keep in mind. And then exercise, a good thing or a bad thing for absorption? What do you all think? So it depends. If you are exercising vigorously, we know that blood flow will be diverted away from internal organs to the MSK. And so then there's no blood flow to move the drug along. And so it sits there and it becomes inactive. But if you're exercising a little bit, then it's good. The blood stays in the internal organs, and then the drug can move along passively. So it really just depends on how vigorously you're actually exercising. Other things to consider, there are drugs, oral drugs, known as sustained release, prolonged release. We'll talk about those too because they fall into the same category. They usually have some type of protective coating, whether that's like 2 layers of gelatin, for example. And the goal of the sustained and prolonged release is that protective coating the manufacturers of that drug recognize that there are barriers along the way, right, to the drug getting broken down, whether that's the first pass effect, right, where it's metabolized by the liver, or whether it's being broken down by the enzymes in the GI tract or being absorbed by the GI tract. So what they do is they develop these sustained or prolonged release tablets, which kind of are more resilient to the metabolization of the liver, more resilient to the enzymes sitting in the GI tract, and they're less likely to be broken down, which means there's more of the drug left over to be absorbed in the small intestine and then distributed across the cell membrane. You can also have what is called a controlled release tablet. The intent of the controlled release tablet is very similar to the sustained and prolonged release, except for what they're trying to do is really lengthen the duration of action of that particular drug. And then you can have enteric coating, which, as the name implies, will move all the way through the esophagus, GI tract, and really won't release until it's in the small intestine. Again, protecting the drug. All of these, really, if you think about it, really truly do protect the drug from being broken down in the esophagus, in the GI tract, from the first bypass effect, right? And all of that is to say to have enough of the drug left over to be distributed over time. Now, of course, there are other routes of administration. Oral is the most common, but we can have what we call is sublingual or buccal. So that's going to be under the tongue, sublingual, and then buccal would be in the cheek. And you see this in this image here. I've done this a lot in patients who maybe have anaphylactic reaction but don't have an EpiPen. I'll put Benadryl, like I'll open the capsule and put the powder of the Benadryl underneath the tongue or in the cheek. What we know about this is, man, there are rich blood supply of vessels in both the cheek and the tongue. And so you get a rapid therapeutic response, much more rapid than taking a drug orally because of all of the different ways in which the drug has to be absorbed, metabolized, and distributed, right? And so then what we also know about this is it reduces the first time pass effect, making more of the drug available to be delivered to the system. In terms of rectal route of administration, the advantages is twofold. If we have an unconscious patient or a vomiting patient, this is a really good way to administer a drug, right? If we have a patient who maybe doesn't like taking syrups and doesn't like swallowing, it can't take a pill because of the cough reflex, then one of the best ways to administer drugs is rectally. So you'll have to decide what works best for you. This isn't something that I've seen in the clinical setting working with adults, but certainly with peds, we can often see drugs administered rectally. And then we have parentally. So we have several different ways in which this can be done. Parentally meaning injection, intramuscular, IV, or subcutaneous. So intramuscular means exactly that, directly injected into the muscle. IV is IV, and subcutaneous is in the subcutaneous tissue layer, right? The advantages, rapid therapeutic response. It's a direct approach to treating, right? Really good for patients who can't take drugs orally, or who have poor oral absorption. So maybe they just I'm thinking about an obese patient who has a lot of adipose tissue who just absorbed a lot of the drug. Apparently I got too excited and ended my video. So the disadvantages would be that you need to be skilled to administer this. So athletic trainers, we can't do intramuscular injections or subcutaneous injections. We certainly can, after you've taken the IV class, do an IV as long as it's within the written policies for your physician. But because these do involve injections, just isn't something that we see in the field of athletic training happening very, very often. So other routes of administration, some that are more common to us, are going to be topical, right? You can have drugs that are going to be applied to the surface. And the beauty of this is that you get this localized approach to treatment, right? And I can think of a few things like iontophoresis or phonophoresis, for example. Those are localized kind of treatment approaches that do benefit your patient. But it can also be like a nasal treatment where you're rubbing drugs inside of the nasal cavity, your eyes and or throat. The rate of the absorption in these particular treatments is really going to depend on the surface area, right? Large surface area versus small. Smaller surface areas tend to be treated better by topical medications if they're lipid soluble, right? We know if we look at all of the layers, we know that the adipose layer is very thick when we're looking at skin layers or tissue layers. So making sure that the cream that we're rubbing on the patient truly is lipid soluble will also allow the drug to be transported to the site of action. And then if we're going to use topical agents, we want to do a few things. We want to increase the blood flow to the skin when we're applying the medication. So the research suggests applying a heat pack to the patient or massaging the patient first to increase blood flow. And then you're going to apply the topical cream, and then you're going to put an ice pack on there. And why would we do that? Why would we put an ice pack after a treatment? It's going to cause vasoconstriction and really localize that drug to that particular area, right? So we have lotions or creams that can be applied, right? We also have ointments, which tend to be a little bit thicker, usually have a Vaseline or an oil kind of base to them. And then most recently, we've seen an increase or a spike in the use of transdermal patches. So your nicotine patches, your birth control patches, for example, your transdermal patches. I'm just giving examples of things that you might actually see in the field, or nitroglycerin patches for patients who have suffered from heart attacks. And other routes of administration, in inhalation, which we'll learn how to do. We actually have inhalers, so this will become an important part of your role as an athletic trainer. The great thing about inhalers is that there's localized delivery to the respiratory tract, which most often, most patients inhaling drugs are using it for some type of respiratory pathology. The beautiful thing about the respiratory tract, again, kind of like sublingual, subbuccal, is that there's so many receptors in the pleural cavity that you get rapid absorption of the drug, right? It's direct, great supply to the lung, as long as the patient is able to inhale deeply to absorb, to bring in enough of the drug to be actually absorbed, right? So we'll talk about these specifically when we get to these specific drug components in the actual class itself. Now we're moving on. That was absorption. Woof. Take a pause, take a deep breath, have a cup of coffee. Personally taking a little bit of my water in right here. So we've talked about absorption. Now we're moving into distribution. Distribution is the movement of the drug throughout the body to various compartments, right? Those various compartments, those are going to be like the sites of action. So it could be the CNS, it could be muscle, it could be the liver, the kidney, the plasma. It just depends on what your goal is for the drug that you are administering to that particular patient, right? Distribution, we've talked about this. You guys could probably give this to me now at this point in time. It's going to be the way the drug is distributed. It's going to depend on a lot of different things, right? The chemical structure of the drug. Name the one thing that helps determine how the drug is distributed. The lipid solubility of the drug, right? So is it more lipid soluble? Is it more water soluble? If it's lipid soluble, we know that there's less resistance. We can use passive diffusion. It can diffuse across the cell membrane and get to the site of action. If it's water soluble, then we know that we're going to have to use probably the active diffusion where we're binding to albumin, we're releasing from albumin, and then moving into the targeted tissue site, right? We have other things to consider, such as the blood-brain barrier, which tends to be lipid soluble and a little bit more selective about lipid solubility, right? And so those are all things to consider. One interesting thing, and it's more down here, and I'm going to skip to it because it was just something that I actually just happened to read, and it's here. The structure of the capillaries feeding the tissue, right? And in particular, I'm going to talk about the placenta, right? The blood-brain barrier, I already said this, right? It's selective, but it's more selective than the placenta. In other words, it has a lipophilic barrier that really is protective at limiting the types of drugs that can enter into the central nervous system. So it is very selective about which lipophilic drugs are entering the system. And that makes sense. It's supposed to be protective. It's protecting our brain, right? The placenta, which is an extremely important anatomical organ, right? It creates the kind of nutrients or the delivery of nutrients from the mom to the baby, isn't as selective. So any drug that is lipid soluble can cross the placenta a lot easier and doesn't have as much resistance as the blood-brain barrier. And one drug that I'm thinking about that is lipid soluble is alcohol, right? So as you start to work with maybe moms to be who might be drinking alcohol, one thing to consider in coaching them is understanding that alcohol gets distributed to the baby because it's lipid soluble, and the placenta doesn't discriminate with lipid soluble drugs, right? So those are all things to kind of consider as you're thinking through thinking through distribution in pharmacology. Now, Let's talk metabolism. So we've got absorption, distribution, metabolism. Woohoo! So we've talked through this a little bit. We have the drug. The parent drug is the drug that actually gets absorbed or rubbed or inhaled or injected, right? That parent drug gets broken down into enzymes, and it gets broken down in kind of one of two ways. Either it's broken down into metabolites by the liver, if that makes sense, right? Or it gets broken down in the gastrointestinal tract or small intestine, right, through biotransformation. But most of that's going to happen where? In the liver. So we either have biotransformation happening in the liver, it's going to produce metabolites, right? The parent drug can interact with enzymes in the small intestine or gastrointestinal tract, and it can produce metabolites. So we have the liver producing metabolites, we have maybe small intestine, gastrointestinal tract creating these metabolites. And then that results in one of two things: either inactivation of the drug, it stays in the GI tract and becomes inactivated within the actual GI tract. This makes it more water soluble, right? When that happens, that's a good thing. It gets excreted. It can't pass through the cell membrane unless there's active transport and binding, but it can get excreted through the kidneys. The kidneys excrete it, and then we have less of the drug available in the circulatory system, which means what? We have to take more of the drug to continue that biological response. The other thing that can happen is those metabolites, right, are active. They travel to the site of action and they have a biological effect, right? These can happen at the same time. I want to make that clear. These enzymes get broken down. This results in metabolites. Either those become inactive, they become more water soluble, they get excreted, right? They can also become activated, delivered to the site of action, and create a biological effect. These two things can happen at the same time. And that's where half-life comes in. You know, when we talk about half-life of a drug where the drug is reduced by 50%, 50% will leave the kidney, the other maybe 50% will go to the desired site of action, right? Most of the time, drugs are broken up through the process of metabolism in the liver. The liver is the major organ for metabolism, which is why it's so important when you have addictions to drugs, as you're orally taking those and ingesting those, the liver typically works really, really, really hard over time to produce those metabolites. And so be very careful about how often you administer drugs to your patient. But again, you can see that sometimes part of that drug is going to become inactive, part of that drug is going to become active. That part will be biological, the other part will be excreted through the kidneys. Now, we could draw the rectum in here because oftentimes some of the drugs that we do take do get excreted rectally, but 90% of excretion most often happens in the actual kidney itself. So here's the excretion process. Excretion, if we were to define it, is the removal of the drug from the body, right? And there are many routes for drug excretion, renally through the kidneys, through the bile, lungs, sweat, and saliva, right? So sweat, naturally, we could produce some of those metabolites and they could live on the skin. But the two most common ways that we see it happening are within the kidney and then in bile. So we can see kind of a drug enters into the system in this direction here. And so we can see how you have the passive diffusion going into the system to go to the site of action. Whatever doesn't get passively diffused or actively transported then gets excreted via the urine. Now that seems very simplistic. It's way more complex, but that's really how it works. And we can go back here to the metabolism screen, right? And we can look at this metabolism screen and go, holy moly, this is a complex system. Or we can go, it's actually pretty straightforward, right? Like if we look at this from a just really, truly basic glance at what it is everything's doing, we have this drug that we take. There are enzymes, right? Those enzymes cause metabolization of the parent drug through biotransformation, or it results in metabolites, right? Most often biotransformation occurs in the liver and it's going to produce metabolites. So you have enzymes producing metabolites, you have the liver working overtime to produce those, and two things are happening at the same time. Activation of the parent drug or the metabolites that come from the parent drug, which cause a biological effect, or you have some of that drug that doesn't get active, becomes inactive, becomes more water soluble, can't be absorbed, and gets excreted through the kidneys, right? And so this is just a fancier way of looking at that. All that to say the two most common sites for excretion in the body really are renally, through the kidneys or through bile. Now, you all are healthcare practitioners, and you will all start working with athletes, and you will all have people who exercise and come to see you and want to take drugs. So it becomes important to kind of at least have a basic understanding of what exercise can do to the drugs that we're actually having the patient take. So we'll break these down one by one. Effect on gastric emptying time. So strenuous physical activity increases gastric emptying time. What does that mean? If I'm working overtime, things are going to move through my stomach quicker, right? Does that make sense? And so then things will get excreted quicker, right? Light exercise decreases gastric emptying time, which means there's more of the drug available to be passed through the GI tract to the small intestine to be distributed, right? So we have to be careful with how much activity we're allowing a patient to do when they take the drug, right? The effect of blood flow on the GI tract itself. One of the things that we know about exercise is it decreases blood flow to the GI tract. So, and this can become a concern because we know that the GI tract can either absorb a lot of the drug, or the enzymes within the GI tract can also cause an inactivation of the drug, right? So if we exercise too rigorously, the blood moves away from the internal organs to the MSK, which means that drug might sit in the GI tract a little bit longer and get absorbed, and we have less for distribution, right? Now, exercise increases blood flow to the muscle and skin, and this is great. So particularly for, let's do it this way, for drugs that we are applying topically for intramuscular subcutaneous injections, we actually want to increase blood flow. We want the patient to exercise so that we have a lot of blood sitting there so that it can distribute it to a very local site. So you have to think through what type of drug are you actually giving. I talked through this already. An ice pack causes vasoconstriction, which means it's going to decrease drug absorption. So first things first, we want the patient to exercise. We want to rub the drug on or inject the drug. And then if we want the drug to stay locally, put an ice pack on it and it'll cause vasoconstriction and keep it right in that area. But let's say, for example, you have a patient ice bath and then you decide, oh, I'm going to rub icy hot on them. That would be the worst thing to do. It's not going to go anywhere. It's just going to stay right at the top of that skin, right? Massaging is a good thing. The massaging allows the drug to spread over a larger surface area. So if that's your goal, massage away. And then moving the muscle has a spreading effect and increases blood flow. So, and this will increase absorption. So all that to say, movement is medicine for the most part. Sometimes though, especially when we're thinking orally, we have to consider how much activity our patient has done before they come in, because orally, if we're thinking about these kind of 2-3 factors, our concern would be if we exercise too much and we redivert blood flow away from the internal organs into the MSK, that the medicine, at least the oral medicine, might sit in that GI tract too long and become deactivated. So those are all things to consider. All in all, this is the end. I hope you've learned a lot about the effects of the body on the drug. We are now moving into the effects of the drug on the body, also known as pharmacodynamics.